So hello and welcome to the Hooked on Health podcast. Today I've got Dr. Matt Most, the Chief of Orthopedic Oncology at UMass Memorial Healthcare. So
thanks for having me, Sean.
yeah, welcome Dr. Most. And just if you can tell the audience a little bit about yourself and your rise into your current role.
So I was born in Brooklyn, lived in New York most of my life throughout school. I grew up on Long Island, went to high school, then went to college in Buffalo, and then on to medical school in Syracuse, and then did my orthopedic residency training back on Long Island at Stony Brook. So I spent 5 years there, and then spent a year in fellowship in musculoskeletal oncology at the Mayo Clinic in Minnesota. And then after fellowship, I took a job at UMass in 2008, and I have been here ever since.
Excellent. What drove you into the sort of subspecialty of orthopedic oncology?
So it's definitely a fairly small subspecialty. It's probably the smallest in orthopedics. So a lot of what we deal with is cancer, and there was a fair amount of cancer in my family growing up. So was touched by cancer a lot, but then worked with an orthopedic oncologist at Upstate in Syracuse, who became a mentor of mine. The types of patients that we saw, the types of cases that we did, what we could do for patients, just really appealed to me. My favorite thing about orthopedic oncology, unlike a lot of my partners in other subspecialties, is that I can treat patients of all ages and all body parts. I joke with my colleagues who do hip and knee replacement that they do 4 operations: right hip, right knee, left knee. And although even every knee replacement has its nuances, to me, if you pretty much just do 4 surgeries, it would get a little monotonous. And so I can operate on patients in the same day who are pediatric to geriatric, from neck to toes. And it keeps me on my toes. It keeps me more interested, because the variety, every day is something different. It just, I never know what's going to walk in the door next, essentially, which, I find very, fascinating. And like I said, keeps me always having to think about different things. It's also, with orthopedic oncology, sometimes you need to be creative. It's unlike hip and knee replacement sometimes, where they can be fairly routine. In order to remove a cancerous tumor or reconstruct a defect, sometimes you have to be creative. You have to come up with things that may have been described once or twice or never described. And so there's an aspect of creativity and ingenuity that comes into play, which I like quite a bit as well.
That's great. Was there a specific patient or a mentor that changed everything for you?
So working with Dr. Tim Damron at Upstate, he was the orthopedic oncologist. He's still in Syracuse, running their program there. But he was extremely intelligent and caring, and like the types of cases he did and patients he took care of was just really inspiring to me. It's sort of one of the things that led me to orthopedic oncology. And then I spent some time at Memorial Sloan Kettering in Manhattan as a resident, working with a fantastic team of orthopedic oncologists there, that also just further solidified my interest in the field and desire to pursue further training in orthopedic oncology. And then after already choosing to go down that path, the surgeons I worked with at Mayo, including Dr. Frank Sim, who's one of the pioneers of the field, just the kind of things that we saw and learned and did were just incredible.
That's great. And you kind of touched on that it's a small, orthopedic oncology is a smaller subset of orthopedics. Talk about, sort of what types of bone and soft tissue tumors, are the most common that you see the most, and potentially what people should be watching out for.
So I take care of, bone and soft tissue tumors of the musculoskeletal system, so the trunk and extremities, arms, legs. They can be soft tissue tumors, they can be bone, they can be, benign non-cancerous or cancerous. The benign non-cancerous ones are fortunately far more common than the cancerous tumors. With bone tumors that are cancerous, most commonly it's cancer that spreads to the bone from somewhere else, somebody who unfortunately has breast cancer or lung cancer that metastasizes to bone, and can cause pain or even lead to a fracture, which can significantly negatively impact somebody's quality of life and function. And so my role there is to stabilize bones that are at risk of breaking or are broken to decrease pain and help restore that function and quality of life in somebody who unfortunately has metastatic cancer. Fortunately, primary cancerous bone tumors, what we would call a sarcoma of bone, they're very rare. There's only about 2,500 cases of bone sarcomas a year in the entire country. Unfortunately, they typically affect younger patients, kids and young adults, which is very sad, but not very common, fortunately. Soft tissue tumors, lumps and bumps, everything from ganglion cysts, which are very common, to lipomas, which are benign fatty tumors that many people have, but cancerous soft tissue tumors as well. So cancerous soft tissue tumors, tumors of the connective tissue, so fat, muscle, nerve, blood vessel, ligament, bone, we call those, again, sarcomas, soft tissue sarcomas. Soft tissue sarcomas represent less than 1% of all adult cancers overall, and there are over 70 different subtypes of soft tissue sarcoma. So it's also very rare, and a lot of people don't know much about it until they know somebody who's affected by it. Basically, anybody who has some type of a soft tissue bump that's getting bigger, that is not related to any type of injury or trauma, is potentially concerning and should be evaluated. With an office visit, potentially an x-ray or an ultrasound or maybe an MRI, but better to get it checked and find out that maybe it's just a hematoma, collection of blood from an injury, or a cyst or a benign lipoma, and hopefully not one of these rare cancerous tumors.
Yeah, so I mean, we obviously see, in physical therapy, a lot of lipomas, and can you tell immediately whether it's a lipoma or something more nefarious?
Not just from physical exam.
Yeah.
You can suspect, if they're soft and mobile, closer to the surface, more superficial, smaller. Things that are big, deep, firm, fixed are usually more concerning, but still no guarantee. MRIs are very helpful. MRIs can be fairly diagnostic for certain things. A benign lipoma we can usually tell fairly certainly from an MRI appearance. But there are lots of things that have a more non-specific appearance that are potentially concerning, and so biopsies are often necessary to determine definitively what the lump is, and based on that, what we need to do about it.
I've heard in clinical practice, because a lot of patients have the little bumps on their low back. Is there such thing as calcium deposits as well? Or are those mostly lipomas that I'm feeling?
A lot of them are probably lipomas. Some of them could be either fibromas or scar tissue or little calcific deposits in the interspinous ligaments or in the paraspinal muscles. Yeah. You can get fibromas of tendons. So lots of different things they could be. And if they're there for a long time and not changing in size, then they're almost certainly not worrisome. But anybody with a lump somewhere that seems like it's getting bigger, better to get it checked.
Yeah. Great. Talk to me about a case, Dr. Most, that sticks with you, where a combination of surgical intervention, and teamwork led to a powerful outcome.
Man, I got a lot over 15 years, but there's one that sticks out that I was thinking about, when I was thinking about some of the things that we might talk about today. One of my favorite patients, I first met probably about 10 or 12 years ago when she was 11. And she unfortunately had a cancerous tumor of the shin bone, the tibia, called Ewing sarcoma, which is one of these rare primary bone tumors for which the treatment is months of chemotherapy and surgery to remove the tumor. And in this case, unfortunately, the involvement of her shin bone was fairly extensive, and our reconstructive options were limited, so our only surgical option, unfortunately, was to amputate her leg. And as an 11-year-old, you can imagine she was not my biggest fan for a little while after that, but she beat the cancer. She went on with her prosthetic leg to be a two-sport star in high school. It was featured in the local newspaper. And then recently graduated from college, where she studied to be a prosthetist. So she wants to do prosthetics to help people who have been through things like she has. So,
wow, that's incredible.
And obviously she had pediatric hematologists who did her chemotherapy, and then a prosthetist of her own to create her prosthetic leg, and extensive physical therapy. So it was quite a team, and now she's 10 or 12 years from her diagnosis, cancer-free, living a normal life, and wanting to give back by working in prosthetics based on her own experience.
That's incredible, huh? And talk about taking a terrible experience and turning it into something that can help people.
Yeah, totally.
You know, let's talk about joint replacement. Your favorite thing in the world: the left, right, left, right.
I joked about it before, but I do like hip and knee replacement as well. I mean, I joke with the residents all the time that I'm not a joint guy.
Yeah.
I'm a tumor guy, but I do a fairly high volume of hip and knee replacement. And those are very satisfying too, because patients will come into the office and I'll first meet them and they're in a wheelchair, and a month or two after surgery, they're walking normal, pain-free, restoring function, quality of life. It's very different than the cancer patients, obviously, but also very satisfying.
Now, your total hips and knees, sometimes they're just traditional hips and knees, or are they usually more complicated?
Most of the hips and knees I'm doing are fairly traditional, routine joint replacement. Because my fellowship training is not in complex joint replacement, if they have a more complicated issue, they would usually see one of my partners that is a fellowship trained joint replacement surgeon. Mm-hmm. But in my training, I did do a fairly large volume of relatively routine primary joint replacements. So, fairly standard run of the mill hip and knee replacements I feel very comfortable doing and do a couple hundred a year.
Because I think I told you the story. My mom had tumors in her knee. They were benign, thank God. Mm. But she had to get, she needed a knee replacement, all those years of gardening and kind of kneeling and, picking weeds and planting her garden. And so she's had both knees replaced, but I think it was her right knee. She had 2 tumors that were fairly large, and so she needed resection of the tumor, and then they had to put concrete or something in there to fill the space. Sure. So it was definitely a more complicated surgery. I think we had talked about that case. But.
Yeah, and some patients have tumors around their joints that need to be removed and reconstructed, and we'll use sort of more complicated, specialized joint replacement prostheses to reconstruct the bone that we have to remove. And so cases like that involve a tumor, I'll still do. Because that would sort of fall into my wheelhouse. But patients with complex trauma or complex deformity, hip dysplasia, things like that requires a different type of specialized training, are usually seeing one of my partners that has that other sort of type of specialized training.
Yeah, no, that's great. What do you wish that every 50-year-old in Massachusetts knew? About orthopedic oncology.
About orthopedic oncology? Hopefully nothing, because hopefully they never need my service.
Yeah.
The tough thing when you start to get into your 50s and 60s is, things start to hurt. And most of the time people assume it's arthritis, I'm getting older. And, as I mentioned before, the most common type of cancer of the bone is cancer that spreads to the bone from somewhere else. And it's not uncommon at all that patients will first find out that they have cancer at all because they start having hip pain that's not getting better, or they break their hip with minimal to no trauma, which is not normal, and it's because they have cancer in the bone. And then we have to do a workup and testing to try and find out what type of cancer it is, where it's coming from. But unfortunately, sometimes the first person they're going to hear that they have cancer from, lung cancer that spread to bone, or breast or prostate, might be from me as part of that workup. So I guess what I would say is yes, their aches and pains are sort of sometimes part of the normal part of aging, but if things aren't getting better, they're not responding to initial treatments, physical therapy, over-the-counter medications, talk to your primary care doctor or see an orthopedist, get an x-ray, don't ignore things indefinitely.
Yeah, we just had Dr. Nair who was on, who's a internal medicine trained MD, and she said that only 19% of Americans regularly see their primary care physician.
I'm surprised it's that high.
So and it might have been, I think it's 1 in 5 people, but then she said that it can actually reduce your risk for mortality by 19% if you just see your primary care physician on a regular basis.
Sure. I mean, there's just thinking about primary care, there's screening tests that are done for a reason, because there are diseases that can be caught early and curable. Things like colon cancer and colonoscopies, or breast cancer and mammograms, that if you don't see your PCP and have these routine screening tests done, you can get diagnosed with these very serious problems later that have become harder to treat.
Now talk to me about, and I'm sure you've had to do this probably more than you have a handful of times. Talk to me about the delivery of that message and what it's like to tell somebody that they have cancer for the first time.
It's challenging. I mean, it's always challenging. Sometimes it's harder than others, depending on the age of the patient, the otherwise health of the patient. A lot of these patients are referred to me from other providers, especially outside orthopedists who don't have a lot of experience with this. And sometimes they will prepare the patient a little bit about what they're concerned about. And then sometimes they just say you need to see a specialist. And then they come to my office. And sometimes they will Google me and see what my specialty is and then have a little bit of an idea. And sometimes it's for a benign problem and they get all worried, and then I can give them good news, which I always love giving people good news that, oh no, this is benign, it's not anything bad. But sometimes they have that inkling when they come in, and sometimes they have no idea. And I try to explain things in a in a way that they can understand. Being very cold and clinical is not a good way to try and share something like that. I try to be positive and optimistic that whatever it is, it's treatable, and we're going to do everything we can to figure out what it is and what else we need to do, and try to maintain your quality of life, your function, your quantity of life as best as we can. And whether they're 20 or 90, it's still hard.
Yeah, that's going to be the worst part of the job.
Can be. Sometimes I'm at UMass with the medical school, and I'll have medical students around with me, and it's not uncommon to walk out of a room after a patient like that and have a medical student say that's about the worst thing I've ever had to see. Yeah. So it doesn't get easier with time though either.
And then maintaining your empathy as you move forward in your career too is got to be, it's tough, because I feel like one of the personal things that you almost try to shut off that part of you to protect yourself, because I'm sure you feel like we're all human.
Yeah. I mean, there's been times when I've had to bite my lip, or to try and maintain composure, or go home and hug my son a little tighter. Yeah. So it's hard, and then trying to separate work life and personal life, and break away and put my phone down and put work away for a little while is its own challenge.
Yeah, I think when you're working with people on a daily basis, or if you're in healthcare, I mean, PT is the same way. We see 10, 12 patients a day, sometimes less, sometimes more, but there are 10 or 12 different stories, that you're hearing, and different lives that you're affecting on a daily basis. And you bring that home with you no matter who you are. I don't care who you're bringing it home. Let's talk about UMass, and what is the hospital doing right now from a community perspective and an outreach perspective that makes you most proud?
So, there's a lot of awareness events, especially around cancer. There's the annual cancer walk that takes place at Polar Park every year to raise awareness and funds for cancer research. We have a pretty big medical school with a fairly large NIH budget in terms, to support research in cancer and the Cancer Center, and the annual cancer walk does a really good job in helping in that area. And then there are other sort of more subspecialized areas. Myself, we do an annual sarcoma strong 5K to help raise money specifically for sarcoma research. There's research and fundraising for pancreatic cancer, colon cancer, almost all the major cancers, to help support research, patient care, looking for those next breakthroughs. I mean, even in the 15 years that I've been in practice, when I started, a patient with stage 4 metastatic lung cancer, lung cancer that spread to bone and other places, the average life expectancy was 6 to 12 months for most of these, and now it's, for many patients, years. Wow. With new developments in treatment, especially immunotherapy and targeted treatments. Yeah. It's been a huge difference just in the 15 years I've been in practice.
So those research dollars are being spent well. Yeah, that's great. If you had a magic wand and you could fix one thing about healthcare, what would it be?
It'd have to be an awful big magic wand.
Tell me about it.
I mean, man, there are so many things that, could use modification, adjustment, from access to what patients have to pay out of pocket if they can, the patient costs to reimbursements. The cost of healthcare has risen exponentially over the last 10 to 20 years, but reimbursements have dropped substantially. So we're getting, the hospitals, the providers, and not just doctors, nurses, we're getting paid less to have to, we have to work harder and get paid less to try and keep up, and it's not sustainable. And a lot of that has to do with the healthcare system overall and how we are evaluated and compensated, whether it's, between things like fee for service and all these other, different types of payment plans and whatnot. It's kind of a broken system. And I don't know that a magic wand can fix that, unfortunately. But it's not just hospitals and physicians. It's healthcare providers across the board. I see what, the stuff that you talk about with physical therapy as well, and the issues there, and so it's
got to be an economically viable profession. There's research that came out, I think it was in the Wall Street Journal. They were talking about there's now a decrease in doctors and lawyers coming through the programs because they just don't pay as well as they used to. And traditionally medicine and even the allied health was a great life, and especially the MD life, you come out and you make a substantial salary given the years that you put into the profession, right? So there's an opportunity cost to losing, the 8 to 10 years that you're in residency, fellowship, and training to become, the professional. But it's got to be economically viable, Matt, for it to work, right? And if it's not, we're going to lose talented people who would join our profession or become doctors or PTs or nurses or anybody in the allied health or medical field to a different track, right? And so it's got to be something that, can pay the bills. And in Massachusetts, it's just a tough place to live and even make $100,000,
Yeah. And, 4 years of college, 4 years of medical school, 5 years of residency, a year of fellowship. When I was a junior resident working 80 to 100 hours a week, I was actually making less per hour than I made working at McDonald's in high school. I actually calculated it as a junior resident. I made more money working at McDonald's in high school per hour. And then you come out of that with, 6-figure loans that, you then have to pay back. And so you have those, 10 to 15 years of lost, income generating years when you're in training, and you're accumulating debt. And then you're, in your early to mid 30s and can get your first real job, so to speak, and have those loan payments hanging over your head. I don't mean to complain. I'm certainly not, living paycheck to paycheck or day to day, and there's a lot of people with a lot bigger problems out there. But I'm still working 60, 70 hours a week. Yeah. And, it takes its toll, and you do want to be, fairly compensated and rewarded for the hard work that you do and what you have to deal with on a daily basis. And like I said, that's across the board, whether it's the nurses and techs in the operating room, the physical therapists, the nurses on the floor, the people in the ED, the people I work with in clinic. It's a huge team, and it's affecting everybody.
And it's scary to think, you really have to have a passion for it. You really want to have to be, or you want to know that you're going to be a physical therapist and that's what you really want, or you need to know that you want to be an orthopedic surgeon. And if you don't know that, it honestly doesn't make sense to follow the track because you don't know where healthcare is going to be in 8 years. I hope it's in a better spot than what it is in now. Sure. But, I would still, Matt, if my girls said, hey, I want to go be a PT, I would tell them it's a great track and it's a great profession. I know clinic owner colleagues that wouldn't allow their kids to go to PT school because they don't know what the future of the field looks like. Sure. Our reimbursement 20 years ago was the same that it is today. Wow. There was basically a dip in reimbursement, and now we're kind of back at what we were 20 or 30 years ago. So it's just the future of, and again, we're in Sutton, we're in the Central Mass community as a business, and you as a physician, I want to be able to I want patients to be able to have access. Mm-hmm. And what's happening is that we've had to cut some of our lower paying insurance contracts because they're 20 or 30% below our cost to offer care. And, I want to offer exceptional care. I don't want to just offer okay care where people are, where we have 15-minute appointments and it's, that's not real PT. So
right. UMass is a safety net hospital. We've had to do similar things with certain carriers that we don't contract with anymore, and it's still hard for the system when it comes down to things as a safety net hospital, because and a trauma center where somebody comes into the ED with a big problem, and you don't look at you can't look at their insurance card. You just got to take care of them. And
right, yeah, it's a scary system, and I think I heard Dr. Dixon talk, I think it was last year at some sort of symposium where we were talking about the future of healthcare, and he was the first one to say that the system is broken, and there is no simple solution.
Yep.
And I think we all try to just do what's right and treat the patients in front of us, but the hard part is the thinking that goes behind things, and how do we build something that's even if it's incrementally better, test, retest, incrementally better, test, retest, because otherwise we're going to be in a one-payer system, and that's going to be the final solution, and then we're going to be Canada. And there's going to be 4-month waits for MRIs, and people are going to die because they can't get in. Yep. And then it creates a whole new elite access to healthcare,
if
and
you
then
have
no access.
the haves and the have-nots.
Yeah,
yep.
And that's what we want to avoid. I mean, I personally want to avoid that at concierge.
I mean, I've heard stories about one-payer systems and Canadian medicine. It's not urgent. You tore your ACL, you'll get your MRI in 6 months, and then surgery the next year.
Yeah.
When I was a fellow at Mayo, we had a patient with melanoma who was Canadian, who was having to deal with that system and delays, and wound up coming down to Minnesota where her daughter lived and got care at Mayo, and unfortunately by the time she got to Mayo, the cancer had already spread. Oh my God. So those delays can really be very costly sometimes.
Yeah. Well, how about a shift to the lightning round? So quick answers, no overthinking. I already gave you these in advance, Matt, so you have to, I know you're ready. One surgical tool that you couldn't live without.
It's probably very cliche as an orthopedist, but I would have to say that the mallet or the hammer, because you can do almost anything with a good mallet. We use it on almost every bone case. I mean, it's hard to pick one. I mean, we need saws and drills, and the power tools are fun too. I think that draws a lot of people to orthopedics, the chance to play with hammers and power tools. Yeah. But I'll go with the cliche and have to say that the mallet.
Okay. Favorite way to unwind after a long day?
Kick my feet up in front of either some sort of brainless TV show or a good sports game, something cold to drink, and just try and not think about the day.
What's the drink and what's the show?
I mean, recently it's been the NBA playoffs. Sorry, Celtics fans.
You're not making any friends with that comment.
No. I'm a sucker for some of the 90s and 2000s reruns. I'll watch some of the same movies over and over again. Anything that'll make me not have to think too much. Recently, I've been watching some of the Netflix true crime stuff, like the Long Island serial killer documentary, and who in Massachusetts isn't at least paying some attention to the whole Karen Reed thing. So,
yeah.
And I'm not going to start any controversy and pick sides.
Smart. Your go-to podcast or your go-to book recommendation?
Not in the middle of anything right now. I do like to read when I have time. Big Stephen King fan. I like mysteries and thrillers, John Grisham, Dean Koontz, those types of books. Stephen King just had a new book come out this week that I'm hoping to find some time to read.
Nice. So more so the horror type?
Horror, thriller. I used to like a lot of the medical thrillers, which I think also sort of pushed me to medical school, like Robin Cook, and stuff like that. I used to love watching ER back in the day, stuff like that. The Pit was something that I actually watched a lot recently. I sort of binged that season a couple weeks ago.
Nice. Cool. So let's say you could design the ultimate day off. No clinic, no emails, just you and the family. What are you doing? Where are you? And what song is playing in the background?
Okay. I'm up in the Adirondacks, where if you go far enough into Adirondack State Park, you don't have to worry about email because you're off the grid because there's no signal. I mean, you drive up the Northway 87 and there's a sign like no cell signal next 100 miles or something like that. Just sitting by the lake, maybe doing a little fishing, maybe just relaxing. in terms of what's playing, it could be anything. I have 650 songs on my playlist right now that spawn 70s to current. And it could be any one of those. I'll just sit back and relax.
So if we opened up your Spotify right now, what's playing on Spotify?
What was just on in the car when I got out of the car? I think it might have been Third Eye Blind.
Okay. Nice. Perfect. Well, this has been fun. Anything that we missed in the show, you think?
No, I don't think so. Thanks again for having me on, and I enjoy being a patient as well.
Oh, yeah.
Here at Concierge. So I've been taken well taken care of here for my myriad of middle-age injuries.
Well, thank you for entrusting us with your care, and thank you for joining the podcast. It's been tremendous.
Great. Thanks.
Awesome. Thank you.